So cardiac system is tough. There's not a lot of PT interventions. With pulmonary PT, we had a lot of interventions: postural drainage, percussion, vibration shaking, pursed lip breathing, active cycle of breathing. We also had devices like the flutter and acapellas and the life vests. Any other interventions? There's a couple I'm missing off the top of my head. Aerobic exercise. Anything else? Puffing and coughing, different airway clearance. So we have a decent amount of intervention. For the cardiac system, we basically have one intervention: exercise. Elevate the heart rate so we can strengthen the heart. But how we do that and all of the information that's required to do that is extensive. And I think this is one of those things where when other people watch how we work in the inpatients, it looks like that we're just walking the patient in an SpO2 down the hall. But the amount of knowledge and safety checks and is this okay and thought process ahead of time to get into that is extensive. So I don't want to spend a ton of time on the anatomy and physiology review. I think we've been through that quite a bit. I'll just spend quickly on the electrical system of the heart. So SA node, so the input into the heart has to do with which nervous system, sympathetic or parasympathetic? Well, both. So which one is going to elevate heart rate, elevate contractility? Sympathetic. And which one's going to tell the heart slow down, go easy? Parasympathetic. Good. So there are some of that will impact it, but the heart itself has its own. You okay? You're dying. Do you want lights off or anything like that? No. Okay. Well, I'm glad I was here for your last few moments. It's been special for me. So the heart itself has its own intrinsic rhythm, so it does not need the input of the sympathetic or parasympathetic to work itself, which is pretty unbelievable. So the atrias will become depolarized with the SA node. The intrinsic rate is between 60 and 100 beats per minute. So that is just our normal values, right? AV node, the AV node creates a slight delay from the SA node. What is important for that delay is that it creates that a little pause so that the ventricles can fill before they contract. So that's the real important thing about the AV node. That little pause just to get blood time to fill. But it also has its own intrinsic rate of 40 to 60. So, 40 to 60, slow, but as long as I'm not moving, we're okay. We're going to make it for a little while. Where we start getting into trouble down at the bundle of his right and left bundle branches of Purkinje fibers, the intrinsic rate of those are only 15 to 40 beats per minute. And those help with ventricular depolarization and contraction. So the reason I put this is because down the road, we're going to get to heart transplant. People with a transplanted heart, that heart is denervated. That means when they go for a run or when they watch a scary movie, it doesn't matter what those feelings are or the demand is, the heart won't change its beat because the heart is relying only on its own intrinsic rhythm, which I find fascinating. But that's why I wanted to pause there for a minute. So systole is the relaxation phase of the heart. Diastole is the relaxation phase, systole, the contraction phase. When we listen to the heart, we're going to hear the lub dub, and that page is wrong. I got that. That's from a different textbook. Don't worry about that. But that when we listen to somebody's heart, what we're listening is the valves of the heart shutting. Those valves of the heart are shutting to not allow that backflow. So the first heart, that lub dub, lub is the S1. That's when the atrioventricular valve closes at the start of the ventricular systole. And then the second, the dub, is the close of the semilunar valves at ventricular diastole. There is a S3 heart sound, normal in children and young adults, but abnormal in adults. So some of the youngest people here, we might hear an S3 sound when we go to do this. For the most part, though, I don't think we will. Most of the time, the S3, which is heard after the S2, is abnormal in adults. So when we hear this, instead of hearing lub dub, we hear the phrase that is Kentucky, Kentucky. So we have a lub dub, one more, lub dub, one more. So this is created by the progressive rapid refilling of the ventricles when the blood rushes from the atria. There could also be an S4, which is an abnormal sound. This is heard before S1. So we have the S4 sound first and then the lub dub after that. The phrase that was taught to me on how to listen for it is Tennessee, Tennessee. So sound lub dub, sound lub dub. And this is created in the second phase of ventricular filling as the atrial contracts, you inject blood into the ventricles. So I think it's the most important for us to understand is anytime we see S3 or S4 sounds, your first reaction should be this is abnormal. With the one exception being in kids, the S3 can be normal and we grow out of it. But make sure that I think that's probably the best place to start for your knowledge here. So murmurs, turbulent flow causing vibrations, almost a whooshing or vibration sound. There are grades 1 through 6, depending on the severity. And again, that's blood sloshing back and forth. Those valves are not doing their job. Valves, what are the two problems with valves they could have? We could either have backflow, right? So that's also known as an insufficient. Yep. So that's blood is supposed to be ejected from the atria to the ventricles and then not allowed to go back to the atria. Well, if that valve is weak and just flops around, that blood is just going to slosh back and forth without getting to the next chamber like we want. And what's the other problem with the stenosis, right? So now it's just, and sometimes it's congenital, sometimes it's part of the disease process, but the valves they're not big enough. So they're not allowing enough blood to pass through at one time. So we could listen to people's hearts. Now, I think in the physical therapy world, this is probably less frequent than pulmonary auscultation. Pulmonary auscultation is so important because if we can listen to somebody's lungs effectively, then we know exactly where the problem is and exactly how to treat it. And especially that where the problem is in the lungs can change quickly. So we shouldn't rely on an x-ray that was taken 3 days ago. We should be listening to it to be really specific now. But this can be really important to detect abnormal sounds. And we would be able to relay that to whoever needs to be. So maybe this person just has high blood pressure, but when we go to listen to their hearts, we hear something abnormal. We can call up their primary. Maybe they don't even have a cardiologist. So we can relay that information. So the aortic over here, one here. So we're going to find the second intercostal space on the right sternal border. Pulmonic, the second intercostal space on the left sternal border. We have two different spots for the tricuspid, the fourth and fifth intercostal space on the left sternal border. And then the mitral or the apex is the fifth intercostal space at the mid-clavicular line. So right in the middle of that clavicle and straight So what I want to do now is we'll get the stethoscopes out. We're gonna try to listen to people's hearts based on this anatomy. So let's try to get there. This isn't exactly going to be easy, but I think with a little bit of practice, we can try for it. The big thing I think for both lung and heart auscultation is make sure that we have firm pressure with the diaphragm of the stethoscope onto them. Especially some of this rib anatomy. Again, we're trying to go in the intercostal space. If that diaphragm is on one of the ribs, if it's not laying flush against the person, that can be a source of error or decreased sounds. Just make sure you have firm pressure with that, okay? So let's take a little bit of time. We got our stethoscopes in there, and we'll try to do some of this stuff, okay? Anybody hear anything great? You hear that crisp valve closing sound though? That's probably what we found here. So yeah, that's what we're looking for. So nice job. So we've already talked about pulse and how do we take it. We've talked about that a heck of a lot already. But here's one thing that I want to make sure we understand. Technically, heart rate and pulse rate are two different things. Heart rate is actually measured from the heart itself, so exactly in the listening to the heart. And pulse rate is measured in the peripheral arteries. That's what we do when we measure, when we have palpate brachial artery, radial artery, anything else. That's technically pulse rate and not heart rate. Now, they should be the same. If the heart rate is different than the pulse rate, that means the heart is contracting but not actually ejecting enough blood to have us palpate it, and that's not a good thing. So, anytime we have that, it's known as a pulse deficit, and that's definitely something that we need to alert the supervising PT or the physician immediately about that. So unfortunately, I and a lot of other clinicians and even textbooks use these terms interchangeably, but they do mean two different things. But let's do a little bit of practice here. So we have one of the most common sites to palpate pulse rate. Radial is an easy one. Brachial, got to do that with the blood pressure anyway. Any others? Carotid, what's the risk? What's the problems with carotid? So the two biggest problems, well, the one biggest problem and the one fear problem. The biggest problem is there's a lot of baroreceptors in those carotid arteries, so that if we don't feel it right away, if we have to go hunt for it, that massage type palpation could stimulate those baroreceptors and actually drop blood pressure and heart rate, which is giving us a false reading. So what if it's really, really high, but we stimulated to make it drop, and now we say, oh, you're good to exercise, but no, that weren't. So that's a real problem. One of the other problems potentially, and this has never been found in the research, but people are still afraid of it, so we'll say it, but it is a little bit of an old wives' tale, is if they have that buildup of plaque in their carotid arteries, that massaging motion potentially could break off a piece of plaque, and then it's going to shoot up to the brain and cause a stroke. So that is the fear, although there is zero research and evidence that says that actually has happened, but that is a fear. So we don't love using the carotid. So it's there if you have to, but we don't love it. So carotid, brachial, radial, any others? Pedal, dorsal pedal, yep. Post-tib, popliteal, and femoral are other ones as well. So let's do this. Let's grab some quick reps on just palpating for somebody's pulse rate. And make sure not only with the number of beats, the rate, we also want to note the rhythm. Is it consistent, or are there skipped beats at all? right? Or they're double beats. Now, I will warn you, there are benign irregular rhythms, and then there are serious irregular rhythms. But it's not up to us in the physical therapy world to know which ones are fine and which ones aren't. If we find an abnormal rhythm, our job is to call the physicians and hopefully cardiologists to alert them. And hopefully they say, oh, yeah, we know, that's fine. Don't worry about it. And that's great. That's great for us. Most of the time, it has like a regular irregular rhythm. So if you're always skipping the fifth beat, typically, like if it's again regular irregular, we can predict this is about to happen. Typically, those are benign and not something to be worried about. And the ones that are a little all over the place are something more concerning. But again, that's not for us to know or to determine that. Ours is just to identify that there's something weird and then call the right people and relay that information. Other things, what other things can affect the rhythm? Yeah, caffeine, things like caffeine. There could also be electrolyte imbalances, especially as we start talking about medications and diuretics. It could have different electrolyte imbalances that could create it too. So be aware of that as we not only do this with each other, but also with our patients. So rhythm and then force, 0 to 4 plus scale is there for that. So let's spend just a couple minutes, palpate at least 2 locations. Do it for 30 seconds, multiplied by 2. If it's the first time you're assessing somebody, anytime you're the first time you're working with that patient, I recommend doing it for a full minute. If they have any sort of cardiac pathologies at all, I would do it for that full minute. Make sure that we're not just doing it shortly, and then the shorter the time, the more risk that we're going to miss something. So full minute for the first time. Subsequent, you can go 30 seconds. But let's do at least 2 different locations for that, okay? Cardiac output is the amount of blood pumped out by the ventricle in a 1-minute period. So at rest, we should be circulating about 5 liters of blood throughout our bodies. So the calculation of that stroke volume times heart rate equals our cardiac output. So if we have really, really strong hearts and they were just pumping out 100 milliliters, well, I need a lot less beats per minute to circulate that 5 liters per minute. So that's why when we have elite athletes with really impressive cardiovascular training, their resting heart rates can be really low just because they're really efficient at pumping out a heck of a lot of blood at once. So one mechanism of how the heart contracts and why is Starling's law. So the cardiac muscle needs to be stretched, therefore it can forcibly contract. So if we increase blood flow to the heart, a more forceful contraction can happen. So just like if we were to blow up a balloon, we blow up one balloon a heck of a lot and one balloon just a little bit. When we let go of them, which balloon is going to fly further? The one that's outstretched further, right? So the heart and the power of the heart can be can be changed with how much blood is in the heart to begin with. Now, that's important to know because not only massage techniques, but other treatment techniques can be contraindicated because we don't want to overload the heart, especially with congestive heart failure. We have to be really, really careful with how we try to address if there's edema in the body. We have to be really careful how we address that because we don't want to overload them. So the ejection fraction is just the percentage of blood that the left ventricle ejects per contraction. Left ventricle ejection fraction, LVEF. Normal is between 55 and 75%. So I always remember just over half out. That's what we should be doing. So almost half the blood should be left behind to give that preload mechanism, so that pre-stretch mechanism. So really important. Now, the lower the ejection fraction, the weaker the heart. So you can imagine I think the lowest ejection fraction of a patient I've seen someone was 25%. So that means, you know, there was 100 milliliters in their left ventricle, but only 25 milliliters would be ejected out per beat. What do you think that does for the heart rate?
High.
It has to be really high, exactly, because if we're trying to get to 5 liters of blood circulated every minute, if we don't have a lot of blood being ejected from the left ventricle, we got to compensate for it with a high heart rate. So you can't, if we, same thing for step length. If I'm going to walk here to there, what do our kids do when they walk by us when they're little kids, right? They're walking the same speed as us, but their rate is way faster, just to not covering our ground, right? So it's the same thing. I can't eject a whole bunch of blood. I better eject as much blood as I can, but really fast and make up for it. So the lower ejection fraction, the weaker the heart, and now, man, that's going to be really, really tough for us. And we have to start talking about energy conservation techniques. And this is the lower the ejection fraction, now we're on the road to this disease is now at a point where you have to modify your life to it rather than let's go attack this. There are definitely medications and other things we can do, but that's the where we have to start modifying what our expectations are. So blood pressure, we should already know a heck of a lot. I think we've covered this quite a bit. Here is what I consider what we need to know for the different stages, although there are different stages out there. So make sure you are aware that different resources will have different guidelines as to what they term normal blood pressure versus elevated versus stage 1 or stage 2 hypertension. So there are others out there. Now, I think the big thing for us to make sure, I think we've got a lot of practice with this. We're going to get another one in a minute. But I really think the big thing that the technique that we have to make sure of, there's a lot of ways we could go wrong, but I think the speed in which we release the air is probably the number one source of error. I think at this point, we're a lot better at opening those valves so it's not that whole whoosh of air out right away. But make sure the speed that line, that the red line, the gauge should be about 2 to 3 millimeters per second. So it is deliberate. I wouldn't say it's slow, but it's definitely deliberate. And I think if we compare that speed to how when we get our blood pressures taken, how quick some people take it, I think there's a lot of opportunity for error and to miss things. And especially when we're talking about blood pressure and is this person safe to exercise or not? We need to make sure we know what their blood pressure is. Because if I release too much air too fast, what if they had high blood pressure but low heart rate or pulse rate, I should say? Well, if we let out too much air too fast, there's a whole lot of space in between beat 1 and beat 2 where maybe that's where their blood pressure is, but I let out too much air too fast. Now I think they have normal blood pressure. Let's exercise, but maybe they were borderline unsafe to. So that is the one thing I think when we have patients with known cardiac conditions, and again, hypertension, I'll have to remind myself of the stats, but hypertension, really, really common. So we should be very deliberate with our ability to take our blood pressure. So why don't we take a couple of minutes and we'll take someone's blood pressure. Just make note of that speed, okay? Let's do that. So all of these vitals have important information of don't exercise if this level hits. So we did that all in PTA 1. So make sure you understand that. I brought this out because this was given to me from that home health course that I took in just earlier. So this has 3 different organizations on what their cutoffs of don't exercise if or terminate exercise if. So a lot of the bigger healthcare systems, one of the guys that was teaching this course, what did he think? I think he said he had 700 different PTs and PTAs that work in that setting. So that is gigantic. So some organizations will have their own guidelines just given right to you. If not, we have these that are available to us. Now, some of them, yeah, I put it in Blackboard. So I just want to highlight here, systolic blood pressure greater than 180 millimeters mercury, don't start exercise. That's the American College of Sports Medicine. Or a drop of greater than 20. APTA, don't start exercise at 250. That to me seems wacky to have that be the number to be the cutoff. I've always had 180 in my head, and I like the ACSM. I think that obviously there's a lot of research and probably some good reasons why it went into all of these different numbers, but I would err on the side of what the most conservative is for all of it, especially when our patients have a history of cardiac disorders. I think we should be ultra cautious. Because again, we can have a long and successful career if we don't make our patients worse. We might not ever get them better, but as long as we don't make them worse, we've got a job tomorrow. But if we ignore one of these and then our patient gets worse because of it, we've got a big problem on our hands. So I wanted to point that out to you. That is in Blackboard for you. Here's a couple of good videos on different mechanisms of the heart. Whoops. So feel free to glance at those if you want. Looking at the lymphatic system is very important as well, especially when we start talking about, well, if somebody has heart failure and lymphedema, how are we going to combat those two things? Because we don't want to overload the heart when it's got a weak heart. So that can be really, really tricky. Briefly, I know we've talked about this in our exercise phys course last semester. So the different energy systems of the body, how do we create energy? How do we get ATPs and use that? Three major energy systems of the body: phosphagen or the ATP-PC system. No oxygen required, used in the first 30 seconds of exercise. Anaerobic glycolytic system. No oxygen required. Glycogen is the fuel source, major source of energy from 30 to 90 seconds of intense exercise. However, lactic acid is the byproduct. And then we have our aerobic system, which now we are using oxygen and used for anything greater than 2 minutes of exercise. We have our different motor units, type 1, type 2B, and type 2A. Type 1, slow twitch fibers, rich myoglobin, used for endurance exercises. Type 2B is activities that require power, so fast twitch, fast response. And then type 2A have characteristics of both type 1 and type 2B. Now, with training, with specific training, we can increase the number of type 1s or increase the number of type 2Bs. Depending on how we're training, the body will adapt to improve upon that. Important for us to understand that as we do exercise, we want to be specific with it. And I think this is something that I needed to underscore a little bit more in the pulmonary section. When somebody's really deconditioned, any exercise is going to help. But that plateau mark happens pretty quick, where the exercise we're prescribing should, if we wanted to make a specific activity improve, we have to do that activity. So my patients always ask me, Josh, how about one of those little pedalers? We can just put it right in front of the recliner and get some exercise. Great. I'm never going to say any exercise is bad exercise, but if you want to get better at walking to the bathroom, we got to get walking. So we need a specific exercise. And if you're cycling all the time, that's a great ways to improve your cycling. If you want to get better at swimming, guess what you got to do? You got to get better at swimming. So if you talk to triathletes, triathlons are swimming, biking, and running, they have to train all three of those. They can't just say, well, I'm an elite swimmer and now I can just do them all. No, you have to have specific training involved. And one of the reasons is because of how these fibers can play into it, but also just the specificity of training matters. All right, so some other diagnostic tests that could be performed. We'll talk about EKGs a lot, different lab studies a lot, and then stress tests we'll spend a lot of time with as well. There's other things as well, but these are the most important for us to know. So the 12-lead EKG is the most common procedure for examination of the heart. There are 1 or 3 leads that could be useful. Anybody have a smartwatch that has an EKG feature on it? Yeah, anybody else? So those are, I think those are 1 lead EKGs. 12 leads is 12 different stickers placed all around the body, and each wire is targeted to a specific area of the heart that it's looking for the electrical current. Really important for myocardial infarction, also for stress testing. So here's what spits out on a sheet of graph paper. Should be this over and over again. Each heartbeat should have this shape to it. So we have our P, QRS, and T sections of this. So the P wave is this heart. That's depolarization of the atria. QRS complex is depolarization of the ventricles, and then the T wave is the repolarization of the ventricles. There are a million other segments to this as well: PR segments, ST segments, PR intervals. When obviously this is only one heartbeat. If somebody was hooked up to EKG, that thing would be spitting out and would be able to read them over and over again. You can count the number of QRS complex. You can calculate the heart rate with that. There's a million different ways to use this. We just don't have enough time to dive into it as much as might be fun. The big things that I want to highlight for you is this ST segment. So if we go back here real quick, this ST segment going from the S to the T and also the T wave as well. Those are where most of our heart attacks that we would be concerned about would start showing up. So, I mean, there's so much more that we could go into with this, but we just don't have the time. And I also don't think that there's a lot of clinical applications, although I do think that in the PTAs, I think you guys could participate in exercise stress testing. We'll look at that a lot. That's definitely a world that you could enter in and be the leads for that. So ST segment useful to detect the presence of impaired coronary perfusion, either ischemia or myocardial infarction, heart attack. ST elevation signifies a large acute injury to the heart muscle. This injury is called this type of heart attack is called a STEMI, ST elevation myocardial infarction, STEMI. This patient is not stable, requires immediate medical intervention. Huge heart attack problem right here. And you can see that here. And the J point is the point in which the S segment turns into the T segment, T wave. So really, if we start looking for that ST segment, that's where that elevation is. That's above baseline. ST segment depression. That's a depression of 2 or more boxes. We could also have T wave inversion. That significant makes us think of ischemia or an acute heart attack that's relatively smaller. This is called an NSTEMI, NSTEMI, non-ST elevation myocardial infarction. So I think these terms are probably new for you, STEMIs and NSTEMIs, right? So anytime you see STEMI, you got to think heart attack. And the NSTEMI I think of as not that bad. As far as heart attacks go, that's the one you'd want. That you want to have any, but that's the one. Now, I think I would not be surprised if on your licensure exam there was a EKG strip picture just like one of these two, and they'd say, "What's the problem here?" So there's so much that we could dive into as far as reading EKGs that we just don't have the time for. What I suggest is the first thing you're supposed to do is look for that ST segment. Does that look normal, or does it look elevated or depressed? And then you could start figuring things out from there. Also, that T wave could be inverted. I think I have a picture of that. Yeah, right here. So here's our normal EKG at the top here. That elevation here, so that's our STEMI and STEMI. There's the depression, and then here's that inverted T wave right there.
Inverted T is the same as NSTEMI.
Yeah, yep. A lot of other different types of lab values. So we've gone over this in PTA 1 as well. So I'm not going to go over it again, but you guys remember how you all learned that for the test and then forgot about it? All right, well, here it is again. So eventually you'll have to, and if you're like me, you probably learned it for the test, then forgot about it, and then you'll relearn it for this upcoming test or quiz or whatever else is happening in this class, then you forget about it, and then you have to do it again for the licensure exam, and then you forget about it. And whether you use it or not in your career will depend on your setting. But remember that it can be very, very important because there are some blood values that is unsafe to exercise. So some of you are going out on clinicals and hospitals next, where this information is. A lot of our inpatient patients will be having blood draws daily, sometimes even more than just once a day. And I think in our skilled nursing facilities, a little bit less frequently, but it still can happen. So make sure we're aware of all of that. Again, all of this stuff we've gone through before. Here are a couple of other ones: sodium, potassium, chloride, calcium, BUN, creatinine, glucose, carbon dioxide, and magnesium, all with the reference values and what the problem, what the causes are, and what we have to look at for that. So make sure you familiarize yourself with that. All right, we've been going at this for a little bit, so why don't we take 10 minutes and then we'll come back and hit the ground for the rest of the day, okay? All right, so got a little bit of time left. We'll do a little bit of medical data collection and procedures that we're going to see in patients' charts, and then we'll go through the physical therapy side. We'll see how much to the physical therapy side. Now, physical therapy side, we've already done most of these things, so not a lot that's new here for us for that, which is nice. Arterial blood gases used to evaluate acid bases. So our blood needs to be, the pH of the blood needs to be between 7.35 and 7.45. Higher or lower than that will a lot of different enzymes stop working, and we can't execute our bodily functions like we need to. So big problem. So PaCO2 used to measure how well the lungs are able to remove carbon dioxide, SaO2, to how well they're functioning to oxygenate the blood. Now, remember when we use our pulse ox, it's SpO2. SaO2 means that blood is collected directly from the arteries and analyzed. So make sure when we're documenting, we're not documenting SaO2. Unless you are for some reason, which is probably you probably made a different mistake while you're doing that. But
We're gonna need to say draw blood, we don't know how to draw blood.
exactly, yeah. So you
So we
shouldn't.
never.
You shouldn't be.
No.
Yeah, yeah. If you are documenting SaO2, and yeah, you've made a mistake well before then. Yeah. So just a handful of terms. Some of it we went over last time with the pulmonary, but acidemia, elevated acidity, which is the pH is less than 7.35. Alkalemia, acidity is decreased, so the pH is greater than 7.45. Eukapnia is normal levels in arterial blood. Hyper versus hypo, I think we all know all of that. So other cardiac testing that we could see, angiography, which is contrast medium is injected in the blood vessels to look at blood flow and the presence of plaque buildup. So this is really helpful when we have a suspicion of the coronary artery disease, although it could happen for any blood vessels. This is really, really helpful for that. Cardiac catheterization, a tiny catheter is inserted in the artery of either the leg or the arm. Advanced intracoronary arteries with a contrast dye injected. This shows the narrowing of arteries and plaque presence. Sometimes also referred to as nuclear imaging, just because of what they're injecting into. X-rays can be important, looking at the size of the heart, lungs, bones, might reveal fluid in different places that we either don't want. Echocardiogram uses sound waves to evaluate lung functioning, could give information on size of ventricles, thickness of the septum, functioning of valves, chambers of heart. Fluoroscopies are fun. Those are X-rays in motion. In this case, used to examine heart and lungs. Not commonly used due to high doses of radiation. I was able to observe with a pain doc where he did injections all day long, and I was able to observe him do pain injections in the spine with fluoroscopy. So it was pretty interesting to see. And then invasive hemodynamic monitoring. That's where we're, again, able to put in catheters and get blood directly from the person to look at a whole bunch of things, including how much blood volume, temperature, blood gases, things like that. So the big thing to remember when we are working with our patients, especially as they're in, I mean, this can happen. I had a patient just a few weeks ago. He had IV antibiotics. So this can happen in outpatient as well, but it's probably more likely in the inpatient side where our patients have things embedded into them. Whether it's one of these things or just an IV line, remember we have to be cautious with that. So make sure you untangle or you position the person in their lines so that if you're going to get up out of bed, you're not getting up out of bed on this side of the bed, but their lines are attached over here. And now we just can't go any further. Also, if somebody's embedded in their arm, we can't use that arm for things like blood pressure. We also have to be careful. Do we actually need to avoid range of motion at all to that? Should we just not use that arm if it's got things embedded into it? So we do need to understand that. I know when my daughter was in the ICU a couple of years ago, that was one thing that I pulled out her IVs at least twice. It might have been 3 different times, and I'd have to call the nurse again and say, "Oh, sorry, I just wanted to hold my daughter." So my daughter's forgiven me, by the way, so that's okay. Angioplasties is with a balloon-tipped catheter inserted in a narrow artery, then inflated to widen the stenotic artery. Often used with a stent to provide structure. So this top picture here, that's the narrowed artery with the plaque buildup. So that is inputted and then inflated, which squishes all that plaque around. So now we've opened up that narrowed area a lot. And most of the time, it's used with a stent. The stent just provides structural support so it stays open. So pacemakers, surgically implanted battery-powered device under the patient's skin, usually left anterior chest wall. This keeps the pace of the heart for us, but that heart rate won't change at all. So we have to make sure we're using things like RPE or dyspnea scale for exercise intensity rather than heart rate.
Wait, so if they're like doing aerobic exercise, her heart rate is still, they never.
Some pacemakers will be able to detect needed changes, and we'll be able to adjust some of the newer ones I've seen on that. But yeah, no, if it's set to 70 beats per minute, 70 beats per minute, yeah.
So they have like restrictions of exercise and stuff, or?
No, but their endurance might be limited because they can't compensate for the increased demand. Yeah. Yep. There's other medications that will have a blunted heart rate response as well. We'll look at that on Thursday, or no, Wednesday. What day is today? Yeah. This whole teaching on a Monday thing feels weird. So anyway, we have to make sure we're aware of that. I also had one coda that's no longer with the company, was just making up vitals, not actually doing it, like documenting it, but not actually doing it. And we were able to see it because the guy had a pacemaker and his heart rate could not have been what, like, it can't, like, you count one, you could count one beat if you do it for 30 seconds and do the math, like you can be a couple of beats off, but this thing is set to 70 beats per minute. It can't be 86 like that. That's wrong. So anyway, be aware of that. If you're going to scam somebody, don't do it to somebody with that pacemaker. So CABG, really, really common coronary artery bypass graft. There's the picture on the bottom drawing of that. So that is surgery to revascularize the myocardium. So the coronary artery is a problem. Typically, a donor vessel of the saphenous vein or the radial artery is used. Could have multiple locations, so that will be dictated. That would be written in the chart: CABG times 1, CABG times 2, CABG times 3. That means CABG times 3 means there's 3 different bypass grafts of this. David Letterman, who had a late night talk show for a long time, he went to his cardiologist for a routine checkup, and they said, lay down, we're doing surgery right now. He had CABG times 5. He was asymptomatic, and then they said, you gotta lay down. You are not leaving today, and we are canceling the rest of my afternoon. We're going after this right now. So pretty incredible. Now, I think I have it. Let's see. All right, yeah, I'll talk about that later then. So that's what that is, just a bypass graft. So if something is blocked, let's just make a little additional little highway so the blood flow can go around that blockage rather than try to go through it. Heart transplant, impaired heart is replaced with a healthy donor heart. Reserved for end-stage heart failure, where other treatments have not been successful. In my career, I got to see one person with a heart transplant so far. Pretty incredible. I think we talk about that later too. Yeah. So the woman with the heart transplant, she was incredible to work with, and I really learned a ton working with her. The only tool I use with her is RPE. We kept her RPE. We want to work hard, but we don't want to exert ourselves. We kept her really, really tight. And when we talk about cardiac rehab in a little bit, in the home care world, we're kind of left hanging out to dry for a little bit. But when I first worked with her, I did a 2-minute walk test because I didn't think she could last the full 6 minutes, and she didn't. She wouldn't have. We did 2 minutes. We barely finished it. She did 120 feet in 2 minutes. 8 weeks later, when we discharged her, she was walking. I think it was a half a mile we got her up to, which was really incredible to see the amount of progress and how quickly it was. And again, the only tool we used was RPE to determine the intensity of exercise. So,
How old was she?
She was in her 60s, early 60s, I believe. Yeah. Yeah, she had a really unique condition that I forget what it was. I'll try to look it up if I have time. So anyway, ventricular assist devices are pretty fun. So that's a miniature pump that's implanted into the chest to aid the ventricle. Temporary treatment for people who are awaiting transplant, although it could be permanent for some people with different heart failures. There are RVAD, which is right ventricular assist device, LVAD, left ventricular assist device, or bilateral BIVA, bilateral ventricular assist. So that's what these look like. They wear this little holster around. They've got the battery pack with it. Make sure we have backup batteries. And something that I have to do in the home care is say, if the power goes out for 3 days, if we get hit by a hurricane or something like that, and the power goes out for 3 days, what are we going to do? How many hours do you have in these batteries? And then what's going to happen if you're on, you know, you have 5 batteries here. What happens if you're on your 4th battery and the power's not back on? What are we going to do to charge these things back up? So that can be important for us. So that's what they look like. I had a woman just early summer. I had a woman with the LVAD device, and she did great. It was really remarkable. But yeah, she's just got to wear those all the time until either she gets a new heart or maybe it'll be it for her. She was young. She was in her 40s. Yeah. Yep. Yeah, and we have to clean all these sites, and I mean, yeah, these sites they're entering the body, so high risk of infection, so they need to be cleaned and changed a lot. And yeah, what's that? Yeah, kind of like an SP tube. I don't know if you ever seen one or heard about one of those, but yeah, that's it. Yep, yep. So those are fun. So some implications with this. So with CABG, we might not be able to palpate that radial pulse depending on where the donor site was. So that be aware of that. You know, I just can't find this well. If that's where they took it, then yeah, you probably wouldn't. I have seen prolonged. This is years later. I can remember one guy in particular. His left leg would always swell, and that was the donor site for his CABG years earlier. This is like 10 years later. So, you know, we are taking blood vessels from one area to add to another. And guess what? If we had a CABG, that means we have coronary artery disease. What do we think about the peripheral arteries? If we have coronary artery disease that's severe enough for a CABG, that the rest of the blood vessels have a high risk as well. Like whatever genetic and lifestyle and dietary factors that created these plaque buildups in the coronary arteries, well, that happened in the peripheral too. The risk factors anyway. We don't know if the plaque buildup is there, but anyway, for this one particular guy, his one leg where they harvested the vein from was always swollen. Sternal precautions used to reduce risk of wound dehiscence. That's the incision splitting open. So what's the problem if we have a surgical incision that splits open? Infection, risk of infection sky high. Plus, we got to make an embarrassing phone call. You know, I thought push-ups would be a great idea with this guy with the open heart, but sorry. So restrictions can vary between physicians. So make sure you're aware of what that physician wants. There's a lot of reasons for it. One, their educational background, but two, they were the ones working on the anatomy. So I haven't done this with a cardiologist before, but with orthopedic surgeons I have, where I've called them up and said, hey, these hip precautions, how strict do you want this person to be? Because their toilets, whatever. Sometimes they'll say, oh no, they had great tissue. They're not going to be a problem. Toilet that low, just educate them and we'll probably be fine. And others, they might say, I was talking with one doc. He called me. He said, hey, Josh, you're seeing this lady next week. I could have cut through her bones with a butter knife. And I go, oh, that's nice, doc. He goes, no, Josh, I'm not exaggerating. That we're so brittle and such little bone mass there. This one, if a stiff breeze hits this woman, she might get a fracture. So please be careful, right? So I'm not looking at the bones. I'm looking at the person, and so it's really nice when we get that type of feedback. So what I will say, some PTs get weird about restrictions and precautions and post-op protocols, and I don't need a protocol. I'm the expert. And I say, yeah, but I didn't touch their tissue. I didn't grab their rotator cuff. I didn't sew in. I didn't put the pin in the bone. I'm going to trust the doc because that's what their job is. So make sure we listen to the physicians, even if it greatly varies between them. That's why sometimes the tissue itself, and others is their education and background. But in general, no exertion of greater than 10 pounds. So 10-pound lifting restrictions is what we would, so lifting, I put exertion greater than 10 pounds. Because when we say lifting precautions to our patients, they think I can't lift up something for 10 pounds. But if the doorway is greater than 10 pounds to push it open, that counts as lifting past 10 pounds. Pushing off of a chair to help you stand up is greater than 10 pounds. So when we say lifting precautions, it's any exertion greater than 10 pounds, not just lifting an object. I think that's a verbiage thing that we have to make sure our patients understand. Encourage range of motion and pain-free range. Some protocols, some sternal precautions limit shoulder range of motion. Don't lift above 90 degrees. Some do not. So again, we have to rely on our docs for what they want. Avoid scapular retraction beyond neutral. So neutral is okay. Squeeze your shoulder blades together is not, because again, how much stress that puts on where the surgery was taking place, and that can easily start ripping those sutures and incisions apart. Avoid trunk flexion and rotation. Avoid use of arms with transfers. Apply splinting for coughing. So that's hugging a pillow. We should be hugging a pillow. And all of my post-heart surgery patients, they all have the same heart-shaped pillow, and it's next to them the entire time. Anytime they need to cough, sneeze, have a bowel movement, they should be hugging that to give them that extra support, so that that area is splinted and well protected. Limit driving. I had 3 guys in a row, all had open heart surgeries, and they all lived kind of close to one another. It was pretty incredible. And one of them, their doc said, you can't even be a passenger in the front seat because we're worried if there is a collision, the impact of the airbag is enough to make us, that's too much of a risk. Now, this guy said, I'm just going to drive. He was getting in his car and driving. So he wasn't exactly compliant. But it's up to me. What is my job as a physical therapist when I see in the restrictions, no driving, no passenger in front seat, and my patient says, I'm driving, I drove to Dunkin' Donuts this morning. Patient education is number one thing, right? The risk is you just had your heart operated on, man. I think you can call a buddy, grab DoorDash. I think we can call, let me know. I'll switch to 8 a.m. appointments. I'll bring you coffee in the morning. Because the risk, and again, the risk, I'm a great driver. Yeah, but you're not the only one on the road. So we have to make sure of that. And also, my job is also to what? So patient education, document 100%. So have to put that. Heart transplant, the heart is denervated. So blood pressure and RPE are more important tools to measure exercise intensity than heart rate. The heart rate will only fluctuate between 60 and 100, right? Its own intrinsic rate. So more exercise is not going to change that heart rate. So RPE yet again.
With the heart transplant, they also can't get up to.
Yeah, the intrinsic, the SA node is only going to send those signals between 60 and 100 beats per minute. Yep.
I don't think liable. They don't pay. We need more, work harder, because it's a real heart, right?
It's a real heart, yeah. But it's not attached to the person's nervous system. Yeah. So there's no, the brain is saying we need more oxygen, but that message doesn't get to the heart because it was never attached. Yeah. Yeah. Yep. So I'll also just say quickly, research bears this out too. My personal experience bears this out too. We can injure and have massive surgeries or massive problems with a lot of areas of our body. When we start talking about the heart, there's a huge emotional connection to that. So be aware of the emotional roller coaster that can happen. The anxiety and the fear can definitely happen because of that. And that's for anything from cabbage all the way to heart transplants. It is something that will probably pop up. So be aware of that. All right, so some other data collections that we could do. Angina pain scale is probably the first one that this is probably one of the few new things that we're going to talk about today. 1 to 4 scale. 1 is mild, barely noticeable. 2, moderate, bothersome. 3, moderate, severe, very uncomfortable, and 4 is most severe or intense pain ever experienced. So we can use the angina scale for our patients, and knowing that, okay, we can get up to a 2, but the second we hit 2, we got to sit down and we got to stop, we got to calm down. We'll talk about some other ways that we can do that with stress testing as well. Uh-oh. Ankle brachial index we've talked about before. We've talked about that in PTA 1. So this is a measure of how well the blood vessels are functioning in the periphery. So 0.9 to 1.1 is normal. And the lower the ratio, the worse things get. So 0.7 to 0.9, moderate. Everything's okay. It's moderate. Probably going to have just normal, but maybe slowed wound healing. But definitely this person needs lots of education because they are on the wrong path. If it gets worse, 0.5 to 0.7. Now we're definitely going to see intermittent claudication. In the 0.7, 0.9, there might be some intermittent claudication. What was intermittent claudication again? Oh, how long ago we learned it. Holy cow. Cam wants to say she just
Cameron, she just wants to say her body. Isn't it, you always got stuck on it.
So it's angina of the legs. What's angina? To the heart, right? So lack of oxygen to the heart, lack of oxygen to the heart because of lack of blood flow. Comes on by activity, relieved by rest. This happened to my grandfather. And the classic story is I went out to rake the leaves or shovel the snow. My grandfather was shoveling the snow. And symptoms of heart attack comes on. Call 911. By the time ambulance gets there, we feel great because we stopped shoveling or raking or doing whatever else. So that's angina. Intermittent claudication is angina, but of the legs, usually in the calf. So we have some sort of that plaque buildup is occurring in the peripheral arteries. So now when we do activity, the demand for oxygen goes up, but because the arteries are narrowed from these plaque buildups, we can't keep up with the demand. The supply can't keep up with the demand, which creates that ischemic pain, usually relieved by rest. So that's intermittent claudication. So early warning sign. So people with the 0.7 to 0.9 might have some intermittent claudication, especially in the more intense activities. At 0.5 and 0.7, they're definitely going to have it. Might need surgeries, revascularization for it. 0.5, now wound healing is unlikely. And then 0.3 is we're going down the road for amputation. There's no way to salvage this. So important for us to know because we are going to be seeing these ABIs in our patient's chart. And I got to say, I think we in the physical therapy world, I think we have such an opportunity to educate our patients far greater than any other practitioner. I think we combine not only knowledge, because our CNAs spend a lot of time with our patients, and while they're really just amazing people, and they work incredibly hard and they provide such an incredible service, but they don't have the medical training that you guys do. It's just flat out they don't. So while they spend a lot of time with their patients, they lack the medical knowledge that we have. And while other people, our cardiothoracic surgeons, have incredible knowledge that we don't have, do they have time with their patients? If that cardiothoracic surgeon is spending time with their patients, the patients are unconscious for it. Like they're doing surgery. There's no what are you doing this weekend conversations. Where us, man, we hit that sweet spot where we actually spend time with our patients. We develop a connection with our patients. I think that's something that you guys felt in your first clinicals that, yeah, we care about even the people I don't care about, I want to see, succeed and make progress. So we develop a relationship with our patients far beyond what most healthcare practitioners do. We get to have a ton of time with our patients. And I know 30 minutes goes by in a blink of an eye, but 30 minutes twice a week, yeah, for 6 weeks, that's a ton of time we get with our patients that they just don't get from other practitioners. So I think the real reason is to understand these things, because we can definitely hammer that education and what's going to happen if this continues. This is a progressive problem. If that does happen, you are looking at amputation. And if something gets amputated, how are you going to move around? How are you going to drive your car? Are you going to live alone like you are right now? So all of that matters. All right. BMI, we talked about a lot last week. So I won't bore us with going over it again, but I do think I'll underline this. We are getting paid based on complexity of patients. And one of the ways we can show our patients are more complex really easy is with our BMI measures. Capillary refill, the time it takes for the capillary bed to refill after occlusion. So all we do is we grab the big toe is the most common place to do this, although it could be anywhere. Big toe, grab the big toe, squeeze it until it blanches, then let go. It should go from that palish color back to its normal skin tone color in less than 2 seconds. Greater than 2 seconds would indicate that there's some problem with the blood delivery here. So that's an easy test. And then the venous refill test we've done before as well. That's where our patient is supine or relaxed. We observe the foot, color, size of superficial veins. And then we elevate the patient's leg 60 degrees, hold for 1 to 2 minutes. And then quickly we sit the patient up, get the leg into the dependent position, and time how much time it takes to get back to its normal appearance, both color and superficial vein size. 5 to 15 seconds is normal. Greater than 20 seconds, blood's having a tough time getting here. Less than 5 seconds, the blood never drained in the first place, which indicate a venous problem. Okay? So let's do those 2 tests, capillary refill test and venous refill test, before we move on. Let's refresh our memories on those 2, okay?
If you brown, does that affect it?
Could. So the next thing we're going to talk about, this might be the last thing we talk about today, is exercise stress testing, also known as exercise tolerance tests. So a formal exercise tolerance test gradually increases exercise intensity to stress the patient to the point of limitation. American Thoracic Society has a protocol with a cycloergometer, 3 minutes of rest, 3 minutes of unloaded pedaling, and then 5 to 25 watts increase in intensity every minute until the patient reaches exhaustion, followed by a 2 to 3 minute recovery phase. Patient wears an EKG the entire time. The heart rate, blood pressure, EKG readings, respiratory rate, RP, rating of perceived dyspnea, SpO2 or SaO2, depending on where you're getting the test done, are all monitored. Also, not all of the tests, but some of them will include the mouthpiece, so we can grab all of our lung volumes and VO2 max at the same time. So the data collected, their true heart rate max and not the estimated heart rate max. Peak or RPD again, not always measured, but can be. Rate pressure products, which we're going to expand on in a little bit. Rate pressure product. So it provides information, one, so we can prescribe exercise in a precise way. So this is the analogy of the 1 rep max test for strength training. 1 rep max set for strength training is the perfect test to do because it gives us the exact number and then we can plunge in the exact training percentages that we want to get it. That's wonderful. Problem with the 1 rep max testing, it takes a long time, lots of exertion, potentially unsafe, especially with poor technique. So there's some downsides to it. This is the analogy for the cardiopulmonary system. So it is a true exercise tolerance test is brutal. You get to your max heart rate, not your, I think it's 220 minus the age. I think it's 190. No. You are going to figure out how fast that heartbeat can go. I know when I did it, I was a young man when I did it. I was, gosh, how old? I don't think I was 21 yet. No, I think I was only 20. And I got my heart rate up to 211 beats per minute. I was cooking. Did not want. So this is brilliant and dumb me at the same time. The professor said, all right, well, we have to do this project. We have to do this exercise stress test. And we all have to write a paper about it. But whoever volunteers to do the stress test doesn't have to write the paper. Man, my hand shot up so fast. And I regretted it because it was brutal. It is absolutely brutal. But man, you can get exact exercise prescription based on all of those readings. So we don't have to estimate heart rate max. We've got your heart rate max. We can also document patients' functional ability, record patients' symptomology, identify change in oxygenation during exercise, if maybe should supplemental oxygen be used or not, identify change in pulmonary function during exercise. So really, really good. I didn't put in this, I should have probably put this into our pulmonary, but VO2 max norms, these are just for adults, 20 and 40. Just how much VO2 max milliliters per kilogram per minute. Women slightly less than men, mostly because of the size of the lungs. Superior in the 50 and above for females. 50 would get us right between the good and excellent categories for males. So we terminate an exercise test if the ST segment elevation is greater than 1 millimeter in the lead without pre-existing Q waves. A drop in systolic blood pressure greater than 10 millimeters of mercury, moderate to severe angina, central nervous system, ataxia, near syncope, dizziness, signs of poor perfusion, cyanosis and pallor. What's cyanosis and pallor? Cyanosis we talked about last time. Blue, what's pallor? Pale, good. Sustained ventricular tachycardia or other arrhythmias. Technical difficulties with EKG or blood pressure monitoring. So if there's something wrong with the equipment, we can't do it safely. Or the patient requests to stop. There are some different types of stress testing. We have an exercise stress test. Good for athletes, good as a screening tool, good for healthy individuals. The endpoint, it could be at maximum, so your true heart rate max, I can't go any more. Or sometimes there's a predetermined heart rate max, typically 85% of the predicted. So that's where we're looking at things other than, we don't really care if we figure out what this person's max heart rate is, but we want to see what their heart does under demand. There's also symptom limited maximal stress tests. So this is mostly applied for patients with history of cardiovascular disease. Not only history, but symptoms as well, because you can have narrowed coronary arteries but not have any symptoms. That's what David Letterman had. So the endpoint, as we just talked about, angina, severe fatigue, EKG changes, or patient requests. And there are other types of stress tests, including a non-stress test, which is just EKG at rest. Also, I've had some patients do a medication-induced stress test. So that's where the patient just gets to sit down, have their EKG hooked up to them, and then their medication is administered to increase your heart rate. And they said it's the weirdest feeling just to be sitting there and all of a sudden they inject something into you and your heart rate jumps up to 140 beats per minute with you just sitting there. So that's what's that?
Like anxiety.
Yeah. Test on Wednesday. So that can happen as well. All of that stuff is going to get a slightly different information. But I think for most of us, we're going to be seeing exercise stress tests or symptom limited maximal testing are the most ones we're going to be seeing. And then we also get to collect. The reason why we're going to see those most often is because those are going to be most important for us to collect data from. The resting EKGs and medication-induced stress tests, those are more monitoring what is this heart doing? Is this heart need additional either medications or procedures to make it work better? One of the data that we could get is rate pressure product, also known as double product. It's an index of myocardial oxygen consumption and coronary blood flow. So it correlates with the onset of angina or developing EKG abnormalities. So what we do is we measure systolic blood pressure and heart rate during exercise. The rate pressure product is heart rate times systolic blood pressure. Reported as a two-digit number, so 10 to the power of 3. Example here, 150 beats per minute with 170 milliliters of mercury of systolic blood pressure equals 25.5, 10 to the power of 3. So what we can use this for is if my patient develops severe angina at 150 beats per minute and we take their systolic blood pressure, then we can calculate the rate pressure product. And now I can use that as a guide to say, I want my exercise to fall below this 25.5. So I can be monitoring heart rate and blood pressure the entire time, calculate the rate pressure product, and either tweak the intensity of exercise. Oh no, we're getting too high. Let's back this down a little bit so we don't reach that angina threshold. Here's a couple of pictures of it. There's a cycle test. You can see this is the one with the face mask that we're measuring the gases, and we can get the true VO2 max. And this other guy on the treadmill does not have that. But you can see all the leads and the blood pressure cuff and everything else monitored. All right, I think the last thing we're going to do are these sit-to-stand tests. The rest of them we've done before. We'll come back to them on Wednesday. So I love sit-to-stand tests. I think getting up out of a chair, getting up off of a toilet, getting out of a car, it's such an important motion to be able to do, but it can also be extremely taxing for our patients. So I love sit-to-stand tests. It gives me a lot of information. It gives me information on their leg strength. It also gives me information on their endurance. It can also, for some of our cardiac patients, our simple manual muscle test, kick your leg out, don't let me move you, that can increase the use of that Valsalva maneuver. So Valsalva maneuver is with sustained contraction, holding my breath to make sure I have enough force in my musculature. Huge problem for patients who have cardiovascular disease. So instead of using MMTs, if we know the patient's going to be using those Valsalva maneuvers, we can do this sit-to-stand test in replace of MMTs to give us a broad look at their leg strength. So both use a standard chair, preferable if it's without arms. 30 seconds sit to stand. All we do is we stand up and sit down for 30 seconds. Norms range from 4 reps for a 90-year-old female to 19 reps for a 60-year-old male. So we can look at the norms. And again, what I love about these objective tests is I can compare my patient to themselves over time. When we first did this, you did 4 reps. Now we did 8 reps. That's twice as good, right? But also we get to say, but for other 6-year-old males, we're supposed to get up to 19. So even though we're making progress, we're not doing what we need to. And I think when you've all seen so far in your first clinicals, how much these insurances like to muck around with our treatments. So it's always important to show progress. That's why we redo tests over time to show our progress. But it's also important to justify why does this person still need physical therapy? Well, when we compare their values to normative data, that's where we get to say this person, while they're making progress, isn't where they need to be. So there's a 30-second sit to stand. There's a 5-rep sit to stand. Norms range from 12. What did I put? 12 in 7s. No, what did I put there? I don't know what the heck. What's range from 12? I don't know what. I think it's supposed to be 12 reps. 20, I don't know what I got to look at what that is. It's in our textbook. I'll glance at that. So for 80-plus-year-olds in 12 seconds or 6 seconds for 20 to 29-year-olds. So let's do this. Let's do both of these tests and then we'll call it a day. So you have one 30-second test and then one you've got to do 5 reps and just time how long. Okay.